clinical trials.
Just wait.
Our presenter is Dr. Yudhvir Singh. He is
No,
associate
wait.
professor.
Shimant, wait. We will start. I will start. I will tell.
Okay, sir.
There will be countdown, then I will start.
So Vinay, you can start allowing people and you can give a countdown.
They're joining.
Hello, friends. We are back with a brand new episode of Rapid GICS Journal Review. And we are going to discuss today an important contemporary, not so different, but not so difficult either, study which has been published recently in the JAMA. Of course, we know that ECMO has been in much frantics because of the COVID, but trying it in position other than supine had been a challenge. But in this study, the investigators have compared ECMO in prone position versus supine position. We will hear more of this about in this today. And let us introduce with our speaker today will be Dr. Yudhvir Singh, Associate Professor from AIIMS, New Delhi. Welcome, Yudhvir. Our moderator will be Dr. Siband Jha from PSRI Hospital, New Delhi. We have our expert panelist, Dr. Shupradeep Ghosh from Escorts Hospital, Faridabad. And as usual, our regular panelists, Dr. Pradeep Rangappa and Dr. Ajit from Bangalore. So before anything, we want to hear the study. But before that, I would like to invite Pradeep to give a small preview on the challenges in prone position in the ICU in the way for the various procedures. And here we are going to listen and follow that. This will be followed by the presentation of the journal club. Yes, Dr. Pradeep.
Thank you. Vinay, can you just share the... Hello, friends. So I'll be talking on this proning in ARDS. So this is a context setting for the journal review that's going to happen, where there'll be discussion on this trial that happened with regards to proning in ECMO. So I'm just going to give a brief overview on conceptual understanding of proning and the physiological advantage of proning and some sort of a hypothetical modeling that has explained the benefits of proning. And then we'll look into the evidence that has evolved in proning. So it's a good topic for all the trainees, DNB or DM students, because this can be definitely be asked as a question. And one needs to have a good clarity on the physiological understanding of proning. So I wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So when we talk about proning, so we need to understand what really happens physiologically. So for all the listeners, for all the trainees, the lung is modeled in a way where a lung is structured as a conical one, which is sitting in a cylindrical sort of a chest wall. So there are these elastic forces that influence the recruitment and the functionality of the lungs against the rigid chest wall. So that is the sort of conceptual understanding that one needs to have to understand how proning helps. So as I said, it's a conical. So lung is looked at as a conical structure. So when you look in the supine position in an isolated lung, so this is the normal lung. As you see, all the alveoli seem to be recruited and they're doing well. All these round ones are alveoli. So, and this is in ARDS. So this is a normal lung. So in ARDS, as you see, there will be some sort of a basal atelectasis and the consolidation that sets in. So there is some sort of a heterogeneity that happens. So we call it as a shape matching. So I've shown I just created a pictorial image for you to understand what shape matching is. Shape matching is the conical lung with its elastic properties matching to the rigid chest wall surrounding it in a diseased lung. So that is what we understand by shape matching. And this and the functionality of the lung is influenced even by the underlying diaphragm and the abdominal sort of a pressure that has a bearing on the diaphragm, which also has an influence on the lung function. So this is what we call as shape structuring or shape matching that happens when the lung gets diseased. And in addition to this, there are three components the trainees can sort of remember as to what affects the lung in ARDS. One is shape matching. Shape matching is, as I said, the conical sort of a lung within the rigid chest wall and the effect of diaphragm. The second one is the gravity. So because the patient is lying down lying down, there is a gravity that has a bearing on the basal structure and that which accentuates or worsens the atelectasis process. Then the third aspect is the compression because the heart itself has a compressive sort of an effect on the basal structure. So these are the three elements that all the trainees need to know. And these three have been derived from sort of a structural modeling or the hypothetical modeling that they have done. So shape matching is one, the gravity and the compressive forces. So these are the three things which leads to the perpetuating or worsening of the ARDS predominantly happening at the basal structure. So if you look at this ARDS lung compared to the normal lung, you see all these basal atelectasis or consolidation, which are not participating in the active ventilation process. So this is typically what happens in the supine position. So these images are in supine. So when you prone the patient, so this in normal lungs, as you see, even in normal lungs, you see there is a nice sort of a recruitment that happens in the dorsal aspect, and so is the ventral aspect, but there is no hyperdistension of the ventral aspect. And then here the shape rematching happens, and then the gravity also has an impact. And as you see, all the basal structures get opened up, and so there is sort of a participation of all the lung units from the dorsal area in the ventilatory function, and this progresses over the time. So this is what typically happens when you prone. So the basal structures get recruited and they participate in the alveolar ventilation. So this is pictorial representation of what happens in supine position and what happens in the prone position. And for all our trainees, just remember these three concepts as to what helps in proning. So you try to eliminate the gravity and then you try to eliminate the compressive forces. So compressive forces is, I'll just show you in the image. And the third one is the shape matching that happens. So again, a pictorial representation. So when someone is lying supine, the alveoli tends to get collapsed. And when you prone, as you see, the basal parts of the lungs get recruited and there is non-collapse of the alveoli. And they re-emphasize this, there is no over-distension of the normal alveoli in the ventral aspect of the lung. That is also an advantage that happens in the prone ventilation. So as you see in supine position, you see the heart is sort of compressing. So this is a supine position. And if you put on the prone position, so you see the heart you tend to eliminate the compressive effect of the heart on the basal portion. So if you see here, heart is putting its compression, there is a compressive effect of the heart on the basal part of the lung. But here in the prone position, you're eliminating and the basal portions are sort of opened up. So this is what you typically see. So this is the compressive effect which you tend to eliminate in prone position. So gravity is something that has a bearing. The compressive effect is what they have a bearing, and there is a shape matching. These are the three components which have a influence, tremendous influence on improving the ventilation when you prone the patient. So this is our conceptual understanding. So this is another important aspect. The original hypothesis of ARDS was there is a ventilation perfusion mismatch. So here you have the basal parts which are atelectatic, which are consolidated. And our understanding is wherever there is atelectasis consolidation, there is a hyperperfusion. There is perfusion, but there is no ventilation happening. So there is a ventilation perfusion mismatch, and this was explained as a reason for hypoxemia that happens. And when you prone, and this gets better. So this was the original hypothesis, but now this concept has been changed to something called where they believe that predominantly the basal part of the lungs contribute to 75% of the ventilation and the apical part, which we traditionally call as baby lungs, contribute only 25%. But when you prone, the reverse happens. So the basal portion contribute to 75% of the ventilation. And the apical part, which is anyway contributing to only 25%, is also ventilated. So this is the current hypothesis to try to explain how prone helps in improving the ventilation. Before it was touted as more of ventilation perfusion mismatch, but now the understanding is because the two-thirds of the ventilation is predominantly happens by the basal part of the lung, which forms the significant chunk of the lung functional units, are participating, that tends to improve your ventilation and oxygenation is our current understanding. And all these are hypothetical, all these are derived from the hypothetical modeling of the lungs in an experimental setup. So you can all take this with a pinch of salt, but this is our current understanding. So when you look at the supine, in supine, the ARDS lung, so this is the shape matching which I was telling. So you are looking at the lung as a conical structure. So this is just the image I've created to make your understanding simplify. Even in exams, they ask you can put this picture. So you are looking at lung as a conical structure within this cylindrical rigid chest wall. So this is the lung. So the basal part is the significant part which participates. And there are these elastic forces. So you are conceptually looking at the lung as an elastic structure within the rigid chest wall, and the shape matching happens even by the influence of diaphragmatic movement and the effect of abdomen on the diaphragm. So this is what we understand conceptually as a shape matching. So when you look at in a supine, so this in supine position, there are three components burdening the lung and affecting the oxygenation, which again I've been re-emphasizing is the gravity, shape matching, and superimposed pressure. When we talk about superimposed, it's the heart, which is applying more pressure on the basal aspects of the lung. So but proning, we are eliminating two components of this. So we are eliminating the gravity, we are eliminating the superimposed. Anyway, shape matching is an innate nature of the lung, which is happening with the compensatory effect of this elastic lung within the rigid chest wall and the influence of diaphragm also. All these are the three components which help in shape matching situation that tends to happen in ARDS. So this is our current understanding. So this image pretty much summarizes what shape matching is. You are envisaging or conceptualizing the presence of lung in a conical format with an elastic features in the rigid chest wall influenced by the movement of the diaphragm and the abdominal pressure. So that is what we understand by shape matching that tends to happen as a natural process of ARDS in a lung. So that is what the current understanding is. So that's about, so this is again the CT images to confirm how prone helps. So if you look at the CT, so this is a CT image of a patient where CT scan was done in supine position. And after 16 hours of prone ventilation, they have done an imaging and you can see how nicely the basal structures are participating in the ventilation. So based on these, they have created this modeling, the functional modeling of the lungs and determined that it is these three components, the gravity, the compressive forces, and shape matching is what determines the advantage or the benefit of proning, what we have understood. So this is a nice image which tells you that how the basal units are fully consolidated in supine, but once you prone, all these basal units have opened up and they're participating in the lung functions, which contribute to 75% of the ventilation. So this is what we understand by the prone. So now, since the talk is more on ECMO proning, so there are a lot of logistics involved when we prone. There are 8 steps that one needs to follow when someone is proning an ARDS patient. I'm sure most of the listeners would be doing proning routinely in their practice, but one needs to keep in mind these 8 steps, and possibly this can be incorporated as a protocol to all the nurses who need to be sensitized to these 8 steps. The first step is pre-proning. One needs to have a checklist to determine as to whether all the tools that are needed for proning are in place and all the uh, the pressure points, all this needs to be addressed. So for that, whatever is needed, so all those are in place. The second one is preparation. Preparation is checking all the lines, checking all the ventilatory connections, and having all the infusions ready, so on and so forth. So all these have to be kept ready. So preparation is the second step. Third step is called cocooning. Cocooning is where you get all the things that needs to be moved in the close proximity so that you can handle everything in one go whilst you are proning. So that is the cocooning. The fourth one, I'm sure most of you would know, is a horizontal move. So when you're proning, you have to take them through three steps. One is you move the patient to the one side of the bed. So that is a horizontal move. And all this happens with at least 4 to 5 personnel present. And the most important person would be the one who is at the head end, who is taking care of the airway, because uh, just remember, this is an ARDS patient who's on a high support, who's on a high ventilator. So, the someone who is managing the airway at the head end becomes terribly important. So, the fourth one is the horizontal move. So, fifth one is the lateral move. So, which means you put the patient on one side, either left lateral or right lateral, whichever side you have moved, and then the final turn where you prone the patient. And the sixth one is swimmer's position, where you put the hand one in the front and one in the back. So this is what is recommended or suggested as the swimmer's position. And after one is done with all this positioning, again you need to look into the final checklist post proning. So in the checklist, you need to see if whether all the infusions are connected back, if patient is on some sort of a sedation, relaxant, vasopressor, so on and so forth. All these have to be ensured that they're all connected back, and hemodynamic stability has to be ensured post proning. So these are some of the steps that are elucidated. So this can be kept as part of your protocol, at least to sensitize all the nurses on the various steps. So proning is not like ad hoc, random procedure. So one need to ensure that the whole safety is ensured by following these steps. So now the questions remain, does proning increase carbon dioxide? Because very often we see that after we prone, there will be some disturbance in the gas exchange, and sometimes we see carbon dioxide goes up. So what does that mean? So after proning, our expectation is carbon dioxide should come down. And if carbon dioxide comes down, oxygen improves. That is a favorable sign telling you that proning is really helping patient get better. And maybe it would help you to prognosticate that patient may do well with proning. But very often CO2 can go up. So why CO2 goes up? Because after proning, your chest wall compliance can come down, and if there is an unadjusted pressure controlled ventilation mode, there is reduction in the tidal volume, because in pressure control, pressure is guaranteed, tidal volume may come down, and that decreases the alveolar ventilation. In volume controlled ventilation, there may be increase in the dead space, and both of these reasons can increase the carbon dioxide. So one has to tweak with the ventilator parameters and see how best one can avoid getting the CO2s to go up. So RV dysfunction, does proning have a bearing on RV dysfunction? So we do understand, this is something I always emphasize in ARDS. One needs to bear in mind, in severe ARDS, RV dysfunction occurs in significant proportion of patients. It is shown that RV dysfunction occurs in 30 to 56% of the patients with severe ARDS, and this has a direct bearing on increasing the 28-day mortality. And the mechanisms why RV dysfunction happens is because there is hypoxemic or hypercapnic pulmonary vasoconstriction that happens, and there can be microthrombi within the alveolar capillary membranes, and there is increase in the dead space. And we did speak in the previous slide as to why dead space increases in unadjusted volume control ventilation. Sometimes the dead space can increase in prone ventilation. All this can lead to RV dysfunction. And there are predictors of RV dysfunction, especially in severe ARDS. PaO2 by FiO2 is less than 150, and CO2 has an important bearing. That's why we emphasize now on CO2 being a poor prognostic marker, and even we have discussed about how CO2 is now become a criteria for someone who should go on ECMO. So gone are the days where we accept permissive hypercapnia and allow patient to have chronic hypercapnia. If carbon dioxide is not coming down, it's very likely that proning is not helping him, and maybe you have to think of an alternate strategy, which is ECMO. So CO2 more than 48 can cause RV dysfunction, and driving pressures if they are perennially more than 18 centimeters. So if patient has any two or more of these, PF ratio less than 150, CO2 consistently more than 48, driving pressure more than 18, they are at a risk of developing RV dysfunction. Does proning help in RV dysfunction? Proning does help in offloading RV, and there is a study for this. So this is a study which is by the French group that came in 2007. So prone positioning unloads the right ventricle in severe ARDS. So this study was done in 42 patients, where patients were prone for 18 hours. And out of this, 50% of the patients, 21% of the patients had normalization of the RV where it was dysfunctional at the outset, and there was improvement in the cardiac index, and there was reduction in the heart rate in 50% of the, which means proning did improve the RV status in 50% of the patients. So even if this happens, then you know that proning is helping them. Even if this doesn't happen, then obviously you have to think of ECMO if proning is failing. So does prone position alter hemodynamics? So very often I see that we say patient is hypotensive, that's why we've not proned. So, and that can be a common reason as to why we don't prone, but it is very clearly shown that should not be a limiting factor for proning, because MAP of less than 65 should not be a limitation. Why we say that? Because when you look at PROSEVA trial, which is a positive trial which I'll talk about, which showed significant mortality benefit, 73%, 70 to 73% of the patients were hypotensive needing vasopressor. So in PROSEVA trial, 72% of them were on vasopressors, which means to say that should not be a limiting factor for proning. So this is an important message that came from this trial. And in PROSEVA trial, it was also shown these patients who were on vasopressors, in fact, the cardiac arrest was less, 6.8% versus non-prone patients, which means to say that proning is beneficial and it does not lead to hemodynamic instability or cardiac arrest, because cardiac arrest in fact was less in this PROSEVA trial. And even in PROSEVA trial, it was shown that the organ dysfunction, extra pulmonary organ dysfunction, 3 days, organ dysfunction 3 days was higher, which is good, which means secondary organ dysfunctions also did not happen in prone patients, which means because many a times we may say patient has an AKI, that's why we won't prone. In fact, the organ dysfunction was less in prone patients. So that's what was shown in PROSEVA trial. So, so what about the evidence for proning in ARDS? So the evidence for proning has been happening over last 30 years. So from 3 decades, the evidence is building up. So just take you through the four important studies which have looked into proning. And all the earlier studies in last 20 years were negative. It was only the PROSEVA trial which became positive. So the first study came way back in 1996 to 99 by Gattinoni from the Italian group. It was a big study, 304 patients. And as you see, they proned only for 7 hours for 5 days. And here they looked at mortality benefit. There was no mortality benefit. That's when we knew that gas exchange improves, but there was no mortality benefit. But please mind you that at this in 1996 to 99, protective lung ventilation was not used. Then the Gurin et al. So this the PROSEVA trial was done by Gurin et al. Later on, but the initial trial by Gurin et al. In 1998, here they did not use protective lung ventilation. They used prone for 9 hours for 4 days, and they followed up the patient for 90 days. And it was a bigger study. 802 patients were recruited, and they were severe ARDS. So when they looked at mortality, there was no benefit because supine and prone. As you see, it was not statistically significant. So it's the same Gurin et al. Who did the PROSEVA trial in 2013, after around 10 years. So 2006, the Spanish group Mancebo et al. They did a study. Here they prone for a much longer time, 17 hours, and the number of patients are 142 for 10 days. Here they use tidal volume less than 10 ml. Again, here they did not show any mortality benefit. So this was the prevailing evidence. And after that, there was this another study by Tepponi et al. From Italian group. Here again, they proned 18 hours per day for 8 days. Here again, they used little bit of protective lung ventilation, tidal volume less than 10 ml. Again, here they did not show mortality. So this was the evidence we had over last 25 years about the proning. So where none of them showed mortality benefit. Then came this PROSEVA trial. So this study, again, as you see, was by Gurin et al., who did the earlier study around 10 years back, came in NEJM. Here they took patients with ARDS less than 36 hours, intubated mechanically ventilated, and prone for 16 hours. They took severe ARDS, which they defined as FiO2 TF ratio less than 150, on FiO2 more than 60% with PEEP of more than 5 and tidal volume 6 ml per kg. So this was a hugely positive study compared to all these previous 4 negative studies. So they had 460. As you see, the previous urine study was done in 800 patients. Here it was 466 patients. 237 were in proning, 229 were no proning. Ventilatory free days, which is good. So the reduced duration of mechanical ventilation was found in this proning and as opposed to no. So ventilatory free days was higher, which is good in proning. And the extubation, more number of patients were extubated in proning group, 81% as compared to 65%, again statistically significant. And the striking thing about this Proseva was there was a mortality benefit, which none of these four previous studies showed. 28-day mortality was 16% compared to 33% in no proning. And tracheostomy was little less, but it did not attain statistical. So this was the compelling evidence to say proning helps. So possibly for all the audience, one could reconcile as to why there was so much of mortality benefit, because all the advances that happened in ARDS with protective lung ventilation. Because if you see the previous studies, they used tidal volume less than 10. Now we are talking about less than 8, less than 6. We talk about 6 to 8. And then we have understood the whole concept of driving pressure. We have understood the concept of PEEP optimization. Possibly all these principles were applied along with proning. So it's not only the proning which has made a tremendous difference. So hugely positive, and then now we all understand this has become a standard of care. After this, there was a meta-analysis that came from the Canadian group, where in patients with PaO FI to less than 100, proning significantly reduced mortality. So this is the current evidence we have with regards to proning. So since the talk is on little logistics, so there are certain contraindications. There are around 7 contraindications, especially if someone has a TBI with high ICP. TBI per se may not, but if they have high ICP, or if they have active GI bleed, hemoptysis, hematemesis, or cervical spine instability, and post-operative patients can be related, especially chest surgery. If someone has had a CABG, post-CABG, or a chest surgery, that can be a contraindication. Now, someone is very hemodynamically unstable with arrhythmias or chest injuries, chest trauma. And here, although I said hemodynamic instability map less than 65, it's a relative contraindication. As we said, in Proseva study, it was shown 72% of them needed vasopressors. It should not be when I say hemodynamic instability, it's an ongoing hemodynamic instability where we have not attained control over hemodynamics. That may be a contraindication for proning. Ongoing hemodynamic instability where we have not been able to achieve stability with vasopressor, that may be the contraindication. So with regards to logistic problems, yes, there are logistic problems with proning, because you need at least 4 to 5 nurses, and you need to have all these cushions to protect the pressure points, and you need to ensure that all the pressure points are taken with these cushions. And there are certain problems that can arise with proning. There can be a lot of conjunctival edema, suffusion, and there can be copious secretions that can come out. And if we do not take care of all those steps, 8 steps of proning, so there can be dislodgement of certain PVC catheters or arterial lines. There can be displacement of the ET tubes or migration of the ET tubes. There can be migration of the Riles tubes, so on and so forth. These are some of the complications that we do see in proning, and these needs to be looked at. And sometimes hypoxemia can worsen, and we know proning can interfere with the chest wall complaints. So chest wall complaints can come down, and that can increase the dead space in volume controlled, and it can reduce alveolar ventilation pressure control, leading to increased carbon dioxide. So all these can be the problems with proning. And one needs to use neuromuscular blockers, especially for someone who is prone. So we cannot just keep them sedated. So they have to be relaxed. That can be a problem. And if they have arrhythmias of some nature, so it is sometimes difficult to manage them if they have a VT or so on and so forth. So these are some of the logistic problems with proning. So that's about in brief about the overview on proning. So summarily for all the trainings, as I said, based on, so there is a hypothetical lung modeling which tells us there is beneficial effects of proning. And when we talk about hypothetical lung modeling, they look at lung as a conical structure within the cylindrical chest wall, which is rigid. And and there is an effect of diaphragmatic also on the shape rematching. So there are 3 components one needs to remember how proning helps. Shape rematching is something that happens naturally in ARDS patient. There is a compressive forces by the heart in the supine positions, which you tend to eliminate in the in the prone position. So and prone position significantly mitigates your RV dysfunction, so that we have seen from the study. And there is no hemodynamic worsening, and this was shown in the Proseva trial because the number of cardiac arrests were less in prone position as opposed to the supine position. And earlier 3 studies or 4 studies in last 20 years did not show any significant benefit with regards to pruning, but the PROSEVA trial and the meta-analysis show significant mortality benefit. So as I've already mentioned, the benefits was due to pruning and all the advances that have happened in our understanding of ARDS with low tidal volume, PEEP optimization, and driving pressure. So the logistic problems do remain. So one needs to take care of all the checklists and the steps for proning, and one needs to be sensitive and be cautious about all the logistic of removal of CVC lines, arterial lines, displacement of ET tubes, migrations of the rail tubes, so on and so forth in back of mind whilst you are addressing this proning situation. So that's a brief overview. So thank you one and all. So,
Thank you, Pradeep. So that was a brief prelude to our today's journal club. And now I move on to Yudhvir Singh to present today's topic on the PRONECMO study. Yudhvir, can you please share your screen?
Yes, sir. Good evening, everybody. So it is visible?
Yes, yes.
Yes, it's visible.
Yes, it is visible. You can start.
Yes, sir. So today the topic of the journal club is prone positioning during extracorporeal membrane oxygenation in patient with severe ARDS. And the trial is the prone ECMO randomized control trial. And it was published in the JAMA. So coming to the basics of the ARDS ventilation, just as it is already explained by the Pradeep's Rangappa sir, and so what are the benefits in the prone position? Already it has been explained by the Pradeep sir. So I'm not going in the detail of the prone ventilation benefits. So why this study was planned? Because there was a retrospective observational study and meta-analysis suggesting accelerated weaning in the patient of the ECMO and also low mortality when prone positioning was applied during during ECMO. So that's why such evidence was supported by the observational studies and the meta-analysis. So this was applied in this study to plan for the randomized control trial. Coming to the methodology, so this is the trial design. It is a investigator-initiated, an open-label and parallel group, and it was done on a multi-center, and it was done at a 14 center in the France, and done at medical and surgical intensive care units. So now coming to the eligibility criteria of the patients. So patient inclusion criteria were adult patients on invasive mechanical ventilation and VV ECMO for less than 48 hours. And these are the exclusion criteria. The patients were excluded. Age is more than 75 years, and if it was less than 18 years, and pregnant patient breastfeeding, VV ECMO initiated more than 48 hours, and the patient was suffering end-stage chronic lung disease, ARDS secondary to abdominal surgery, moribund condition, and simplified acute physiological score more than 90, and irreversible ARDS with no improvement in lung function. And if the patient has gone on lung transplant, and there are certain contraindications for prone positioning in patients. So according to how it was randomized, the question was randomized on a web-based system using the minimization, and enrollment was 1:1 ratio in prone ECMO group and supine ECMO group. And in supine ECMO group, it was permuted in a block size of 4 and 6.
Yudhvir,
Yeah.
can I interrupt?
Yes, sir. Yes, sir.
Is there anything mentioned that within how many hours of invasive ventilation the patients were taken?
So they things are they have initiative on no weakness. It was
within how many days of, was there any criteria, inclusion criteria, exclusion criteria, that within that, like any other intervention in ARDS ventilation, the more we delay, the
Here
more
there was
the
no time.
one day.
Yeah,
So
yeah.
they were just following the EOLIA criteria. I can't exactly remember.
So they have mentioned regarding the
Yeah.
EOLIA criteria. They have undergone through the EOLIA criteria. They have not mentioned in detail regarding how much the patient was intubated before starting the for the ECMO prone position in ECMO.
So there's a
So
significant difference from the PROSEVA trial, where the patients were included very early in the ARDS. Okay.
Sir, in that earlier trial, that there were 7 days, that selection criteria they took. Probably what I have seen is probably 1 day.
Okay, but the PROSEVA trial inclusion was in a very early.
Yes, sir.
Here actually there was no relation because they had to be on VV ECMO for less than 48 hours.
48 hours,
This
yes.
was
Randomized.
basically.
Okay, we'll discuss it in the later.
Okay. So this was the randomization. So now about the trial intervention for PRONECMO, 4 prone position sessions were given for 16 hours during the first 4 days. And early prone stopping criteria was that oxygen respiratory system compliance improvement. And the patient is improving on the respiratory system compliance, or there is an ECMO is winning. And partial pressure oxygen if deteriorated after 16 hours of the prone position, and that deterioration should be 20% more than the supine. So that was the criteria to stop the proning in that such patients. Regarding the supine ECMO group, prone position not allowed while undergoing ECMO before 60 days. So it was not allowed before 60 days. The physician can place patient in prone position as a rescue therapy in case of refractory hypoxemia. So this was the condition. Now coming to the what outcome analysis they have done in the primary, what are the targets of the primary objectives? The target was the time to successful ECMO winning within 60 days. How many patients we win from the ECMO within 60 days? And what was the criteria? The ECMO winning considered successful if patients survive without ECMO or lung transplant for 30 days after his discontinuation from the ECMO. This was the primary outcome and the criteria. 2 competing events were noted on: winning failure, and the definition was need for the second ECMO or lung transplant within 30 days of the ECMO withdrawal, and if patient is death while undergoing the ECMO. These were the 2 competing events. On secondary outcomes, so all cause mortality at 90 days follow-up, and time to achieve respiratory system compliance more than 30 ml centimeter of water within 7 days, number of days alive without cardiovascular and kidney failure, and incidence of ventilator-associated pneumonia. ECMO and mechanical ventilation free days were counted, and also length of the ICU stay and the length of hospital stay. And the need for veno-arterial ECMO at 60 days and 90 days follow-up after the patient was weaned from the ECMO. So now coming to what are the adverse events noted during this period. So skin pressure injury daily for first 7 days, and unintentional decannulation, non-scheduled extubation, whether the plan was whether the patient was weaning, and what about it was not able to wean, but there was an accidental extubation. Hemoptysis, the patient has a complaint of hemostasis is occurring, and cardiac arrest, and all assessed, and all these parameters were assessed at 60-day follow-up. And sample size were calculated based, coming to the sample size, it was calculated based on the data from the randomized controlled trial conducted in severe ARDS undergoing PV ECMO that was happening in the France. So it was it was calculated if cumulative incidence of successful ECMO winning in the control group of considered by at least 60% in the presence of the competing causes death. So in later chart studies, the patient was 170% were analyzed. 85 per group were 85 per group were required to have 80% power to detect a sub-distribution hazard ratio of 1.75 with a power of 95%. So this is the sample-wise calculated in such patients. So now coming to the Now coming to this, how does the
criteria. Which patients were excluded from the trial you are talking about?
results? Actually, this. So now coming to the statistical analysis. So baseline characteristics are reported as counts with percentage or categorical variables. Mean with SD and median with a continuous variable. Cumulative incidence of successful ECMO winning was compared between two groups using the gray test, and hazard ratio was estimated for the using fine and gray computing risk regression analysis. And the categorical outcome were analyzed with Fisher test, and continuous outcome were analyzed with a Wilkinson sign rank appropriate, and certain outcomes were censored, that is death, and so in between that, and that were analyzed over the Kappa barrier curve, or analysis were conducted at two-sided with a statistical analysis, two-sided test. So now coming to the the trials, the patient recruited. So this is the 250 patients with severe ARDS undergoing VV ECMO assessed for the eligibility. Okay, and in this 170 patients finally recruited, and 80 patients were excluded. 19 had a surrogate decline, consent, 9 contraindication to prone positioning, 9 initiation of VV ECMO at 48 hours, and 6 were moribund, and these are the various regions mentioned here. Finally, 170 patients were randomized, and 86 randomized. Among these, 86 randomized to the prone position during ECMO, and 84 randomized to the supine position during ECMO. And in these 86 randomized to in ECMO group, 86 including the primary analysis, and in the supine ECMO group, 84 included for the prime analysis. Now coming to the results, so we are discussing about the baseline characteristic. What we are seeing that the median age overall was 51 years. In this both the group, we combined it, and in baseline characteristic it was not significant, and about 60 patients were female in both the group. If you discuss regarding the comorbidities, so comorbidity is also comparable in both the group, ECMO and supine ECMO and prone ECMO. Now coming to the baseline characteristics of the time from the ICU admission to intubation, the median, it was around 1 day, so 0 to 4 days are the time interval days range. Time from intubation to ECMO, it was 3 in the prone ECMO and 4 or 5 in the supine ECMO. So it was also not significant. Time from ECMO initiation to randomization, so it was also not it was also not significant. Coming to the ARDS, so most of the patients in this were COVID ARDS. Most of the patients, only 6 patients has a bacterial pneumonia in prone ECMO and 3 in the supine ECMO. Pre-ECMO parameters were also compared, and in that also, sir, plateau pressure and respiratory system compliance were comparable in both the group. And PEEP was also both comparable in both group. 12 was applied, and Tada volume was again 5.9 ml per kg and 6 ml per kg. Now coming to the results, in this PSCO2 was comparable 54 and 59, and it was not significant also. And then coming to the prone positions, number of session what in prone ECMO it was 2 sessions, and in the supine ECMO it was 3 sessions. And use of neuromuscular blockade, it's 78 patients and nearly 65 patients. Steroid were also used in that patient, so 22 and 20. Recruitment maneuvers were used on 4 patients and nearly 6 patients. Pneumothorax incidence is also comparable.
Yudhavir, again, I need some clarification. You said that in the no ECMO group also 94.1% of the patients received prone ventilation. That's what you mean? Prone positioning? In the even in the control group, I can see that. Can you just clarify it a bit? In the
Just a minute.
control group, prone positioning, number, and percentage in this slide.
In prone position, in prone ECMO group, no, sir?
Next slide. Yeah.
Yeah, next slide. I'm coming. So in prone group,
Next slide, please.
this is the
Next
52 patients.
That is
No,
the
this
age.
is the age.
Age.
Sorry, age.
Go. Next slide, please.
Yeah.
Yeah. You see the prone adjunctive therapies, prone positioning.
Yes, sir, prone positioning. 85%.
98.8% of the patients in both groups, more than 90% of the patients had the similar type of intervention. Is it so?
Yes.
Adjunctive
Yes.
therapy.
No.
Yes, sir.
So no, sir, if this is the prone position 85, we were given in the prone positioning number of session to 79. So that you are telling.
Yes.
Okay, sir.
Almost around 95% of the patients had received prior proning before randomization.
So before.
Yes, sir, they are them.
Sir, before initiating
randomized.
Yes.
Before initiating ECMO, these are things.
Okay, that's great. So this is pre-randomization.
So this was the this was the
Pre-randomization.
It's a baseline.
Baseline, yeah.
So these are all taken as the baseline characteristics at the it were comparable in respiratory system. SOFA score was also comparable, and P was also comparable. Tidal volume, driving pressure, 14, respiratory rate, respiratory system compliance. This was also comparable. Now coming to the baseline participant characteristics at the cannulation ECMO settings. So both of the patient femoral, jugular, 85 and 82. This were, and ECMO flow was almost 4.8 liter per minute in both the group, and sweep gas flow also was 3, and it is 4 almost, and receiving vasopressor inotropes almost 50 and it is 46. This is the baseline characteristics of the patient. Now coming to the primary results in successful primary outcomes, that was the target, and successful ECMO weaning by day 60. This was the prime objective of this study. So in the ECMO group, prone ECMO group, it about 38, and it responds about 44.2%, 44.2%, and in supine ECMO it was about 37, and so the median and mid difference was 0.1, and relative 95% difference was almost 1.11. And the competitive events at death before ECMO weaning, 32 in a prone ECMO patient, and also in supine it was 31 almost. And ECMO weaning failure, if you count, so it was 9 in prone, and in supine it was 3. So it was this value was significant in the prone patient. Now coming to the secondary outcome analysis. So in this also what we're seeing that the respiratory system compliance on day 2, it was compared, and on day 7, it was also comparable, and it was not significant. And coming to the day alive and free from kidney cardiovascular within 7 days median, it was 7, and 7% in 7% free from kidney disease and day alive. And then for cardiovascular, 5 and 5. VAP incidence, it was greater than 1 ventilator pneumonia episode in 73, it was also comparable. As a rest other findings, days alive and free from mechanical ventilation by day 90, it is none of the patient 0 and 0, sir. Yeah.
You can go fast, Yudhvir, if nothing is significant.
Nothing is, sir. Now coming to this adverse event, sir, in adverse event, sir, also we see the cardiac arrest event. So cardiac arrest was reported in 3 patients in the prone ECMO and 11 in the supine ECMO. So it was significant more in the supine ECMO that causes maybe maybe there's a patient-specific bleeding event required packed red blood transfusion. It also not significant. Stroke, that also not significant. And so then see this score. Now coming to the incidence of successful winning failure and death by the positioning. So this is the analysis. So winning failure. So in in this patient also, so there was a for 60 days analysis was done, and also the death analysis was in this patient was compared. So coming to the sub hoc, a post hoc analysis was done in this patient, and we also found that there was compare with respiratory system compliance and body mass index and high ECMO volume centers. So in this also, sir, there was no significant difference was observed. So now coming to the discussion, in this RCT, patient with severe ARDS receiving VV ECMO and VV ECMO, early application of prone position during ECMO was not associated with any shorter time to successful ECMO winning. And regarding the secondary outcomes, the survival at day 60 and day 90, which was compared with ECMO application and mechanical ventilation free days and ICU and hospital length of stay were not different between the PRONECMO group and the supine ECMO group. And the various retrospective cohort studies receiving VV ECMO has showed that the prone positioning during ECMO was significantly associated with a greater probability of being alive and weaned from the ECMO. And also the recent systemic review and meta-analysis supported this. And it was done on 1836 patients from 13 observation study. It showed that the prone ECMO position, prone positioning during ECMO was associated with significant improvement in ventilator-free days and ICU survival. And the relative risk was 1.31%, with confidence interval of 95%, 1.21 to 1.41. And present in both COVID-19 and non-COVID-19 patients receiving the ECMO. These were comparable in both COVID-19 and non-COVID-19 ARDS. So shorter duration of ECMO support may decrease the ECMO-related complications, which are hemorrhage, neurological events, and nosocomial infections, and decrease resource utilization. The observation studies, whatever conducted in the last few years, has shown promising results regarding the prone positioning of patients undergoing ECMO, which ECMO failed to reduce the ECMO duration and mortality in this RCT. So whatever the observation study has shown the promising result, but this RCT shows that it does not benefit or reduces the ECMO duration as well as the mortality. So whatever the reasons explained by the author is that the majority of the enrolled patients were placed in prone position before ECMO, and it was compared with widely variable proportion of patients in previous cohort. Were placed in prone position before ECMO in this. Secondly, the majority of the patients had COVID-19 related ARDS. So in this study, most of the patients were COVID-19 related ARDS. Or maybe the COVID-19 related ARDS have a more, they are more severe, and they are have a more pulmonary injury. So that can be one of the reasons for that. And another prior international cohort suggests that COVID-19 that was used during the ECMO which was used during the COVID-19 period was given for longer duration and also the ICU length of stay. It was longer ECMO, and ICU length of stay was more in the COVID-19 patients. And that was reported also in the ELOA trial. Okay. And so thus it remains uncertain whether the current trial findings can be generated to patients with non-COVID-19 related ARDS. So it is still under investigation, or it cannot be generalized. Other reasons for this neutral result in this RCT was that etiology or severity of ARDS and subsequent biology may be different in COVID in maybe different in COVID-19 patient when given prone positioning. So that was the one reason, other reason given. And in this also, the 60-day mortality was 44%. It was 44% mortality was reported, which was greater than reported in the cohort study with COVID-19, which was done in undergoing ECMO, which was done earlier in the France at the start of the epidemic. So that in the start of the epidemic. So that may be one of the other reason that COVID-19 variant that may respond differently to the prone positioning and also depend upon the type of the COVID-19 variant. But this contrasts with the early report of prone positioning benefit in COVID-19, which was published in the which was given in the patient with a wild type of SARS-CoV-2. In such patients, also the ECMO was given, but the results were contrasting in comparison to the COVID-19. So coming to the limitations, firstly, the sample size. The author recruited 250 patients, but finally the calculation was made in 170 patients. So the sample size may be insufficient to draw any conclusion in this study because already ECMO is applied only to 7% of the ARDS patients in severe ARDS across globally. The use of the ECMO is only 7%. So even in the large observational study, which was performed before the COVID-19 pandemic, that also reported the same. A rate of ECMO would have been even lower if the ELOA criteria for ECMO initiation had been strictly applied. In this, especially with the systemic use of prone positioning before considering the ECMO. Means if we go give prone positioning, then we go for the then only can we consider for the ECMO. If prone positioning has failed, then only we can try for the ECMO. So this was relaxed in this study. Secondly, 69 of 170 patients were enrolled from a single center only. So it was a multi-centric study from 14 centers in France, but 69 patients were enrolled from a single center, and that center maybe has a high expertise. So the result can vary according due to the that also. But whatever the good aspect of the study was that 170 170 out of 250 patients screened during study period included in this randomized control trial, suggesting that that the inclusion criteria were broadly applicable to this patient because only 80 patients were excluded. Thirdly, since this RCT was unblinded, because you are doing the nature of intervention cannot be blinded because you are proning the patient, so there is chance of the bias in this study. So finally, to conclude, among patients with severe ARDS supported by the VV ECMO, prone positioning during ECMO did not significantly reduce time to successful weaning of the ECMO.
Thank you, Yudhvir. So we will have to quickly start our discussions and stick to the important points that are raised. First, I go to the question that was raised by Dr. Ghosh. And probably, although the authors have not discussed during their limitations, I wish to start by asking our expert panelist, Dr. Ghosh, then I will move to Shrimant and then to Pradeep. But first, Dr. Ghosh, do you think the same question that you had asked, that many of these patients might have been on prone initially, but later following randomization, they might have become supine. Similarly, patients who were supine might have been made prone, and probably this kind of mixed match could have been resulted in neutral results. Do you think it's a possibility?
Okay, thank you, Anirban. And I must congratulate the authors for doing such a fantastic trial in such a difficult scenario of COVID. And I'm amazed to see the number of adverse events. It's so less in number. There is not a single event of decannulation during proning and supine.
Yeah.
It's an amazing thing. coming to the prone position, we know
going
that
to the question that he asked you, going to the question, yeah.
Coming to that, no, don't be like that Goswami or Arnab Goswami. Eh? So, we know the benefit of again. There's heartening to see the amount, the number of. If I remember correctly, in the earlier trial, I think approximately 70% of the patients were prone prior to randomization in the this thing. But in this trial, more than 90% of the patients in both groups were prone prior to starting the
randomization. Prior to randomization.
That's a beautiful. That's a triumph of prone ventilation. Another important thing is, yes, I do agree that there is some confounding. There is some confounding. One is if you see that. If I can correctly think, the patients were intubation to randomization was roughly around 4 days in the prone group and 6 days in the supine group. There was a delay. Prone ventilation.
But it was not significant.
It was not exactly calculated in this fashion, so we do not know the significance.
No, it was calculated. They had calculated, they did not find any significance.
It was broken in two different things. First is how much time it took for the ICU admission to the intubation.
Correct.
Intubation they have broken it into 3 groups. So, but if we sum them together, so around 4 days for prone group. Important thing is that both this group, they received around 3 to 5 sessions of proning. So proning already failed in these patients. Proning already failed in these patients. That's the reason this thing. So I think and it is too much of an expectation probably that you need to have a much bigger trial, bigger number of patients, large number of patients to get a benefit, because as such these patients had failed proning. To get another benefit from proning, you need to have a much larger number. Purely the PROSEVA trial has included something around close to 700 patients, close to 500, around 500 patients. Yeah, around 500 patients to see a benefit, but with a much less sicker patient. But here you are.
Dr. Ghosh, yeah, probably it is true to see. The PROSEVA trial looked upon the prone ventilation per se. They're looking upon.
Ultimately, Anirban, what we are trying to see is whether proning is having additional benefit in patients who are on ECMO. That's what the trial is trying to see. So basically, it's in a subgroup of patients who are already on ECMO, whether the additional proning sessions will have any benefit or not. To see that, the patients who had already failed proning, you need to have a much larger sample volume. And I'm sure it's very difficult to get a sample volume like this in such a scenario.
So do you think that only patients who had, because all of this
study has not answered the question. The study has failed to answer the question yet. We need to have a larger study.
No, but you see, all the patients who were on ECMO can be naturally supposed to have failed proning, because proning has been equally distributed in both the groups, both the prone ECMO group versus the.
Both the groups have already received three sessions of proning.
Correct.
3 and 4 sessions.
So, I am talking about the proning after
already, anyway, 4 sessions of proning, if they are not showing any improvement, it is technically a proning failure.
Yeah, it's a technically proning failure. I fully agree with that.
This is such a sick patient, serious subgroup of patients. Getting an additional benefit of proning, you need to have a much bigger study, much bigger sample size, and the process.
I get it. But another thing, very important thing, I will go to Pradeep for that. Do you think that
if I can just add one point, so Supradeep made excellent, valuable comments. But Supradeep, if you look at the primary outcome, their outcome was not to see mortality benefit, which you would say that it is an additional benefit we are looking. What they have looked at time for weaning from ECMO. So all are ECMO, and what is the time that you would take to wean? Both are on ECMO. So which means again we have to keep the physiological standpoint that proning will recruit this basal alveoli, helps in healing of the rested lungs better than someone who is not prone. So I'm looking at that perspective that they were still, they did not achieve that outcome which they were looking for. So you
Yes.
can get that little
Fair
subtle
enough.
difference,
Fair enough.
Supradeep.
Yes. There is a difference. There is a difference in the primary outcome. But they also looked into the mortality benefit in 60
That was
days,
secondary.
7 days.
secondary outcome.
These were secondary outcome. This
And-
primary outcome is only for the purpose of statistical analysis. We all.
Yeah, but the sample size is calculated only for primary
So
outcome.
it is, and they wanted to see the primary outcome which can give them the lowest number of sample size.
Absolutely. And while calculating the sample size, if you see, it is based upon the assumption that in the control group, the weaning will be in at least successful in 60% of the patients, whereas even in their study, it was only 44%. Don't you think that this expectation is too high? 60% successful to be on ECMO weaning?
Absolutely. So they wanted to reduce the number. Because
So that's why they have,
even if you see the Eulia trial, even in that also the winning success was ECMO winning success was around 45, 46%. If I remember correctly. So expecting 50% is too much.
So probably that has taken down the number of the sample size has reduced that way. Yeah. I'm coming to that. But most importantly, what they did not mention, I'm going to Ajit for this. Ajit, what do you think? Why do you think that the patients in the supine group had more cardiac arrest? Which was significant. The only thing that was significant in this entire study was more cardiac arrest in the supine group. And they had no explanation for this. Yeah,
You're muted, Ajit. You're muted.
No, even I don't have an explanation because I was expecting more adverse even in the ECMO group. As Dr. Supradeep was mentioning, I was worried about, and here is mentioning that the 4 sessions, it is not only that, the 16 hours of, the proning, it is around in 4 sessions, 4 hours of 4 sessions of 4 hours. That means you mean to say that you are trying
not
to
4 sessions of 4 hours, 16 hours.
16 hours, but it is
right.
4 sessions actually, in 4 hours, 4 sessions. So that means, 4 times, they would have turned the patient. It was really amazing actually. As you said, I can't believe how they managed, the dislodging or the potential dislodge in the tube.
Hats off.
Yeah. So I don't have an answer. You're right, because maybe it is not statistically significant. That much I can tell you. But the only thing is that, I know the retrospective studies and the meta-analysis have shown that, I know there is some kind of a decreased mortality and some kind of a weaning benefit, early weaning with these kind of patients who are prone on ECMO. But but my single sense of thinking will be that when you are putting the patient on ECMO, see that itself you are giving a very good, I will say, when you talk about the ARDS ventilatory lung protective strategy, you are giving ultra protective strategy. You are giving a tidal volume of around 2 to 3 cc, maybe here around 4 cc, I believe. And you are giving a PEEP of 12, and you are always keeping the plateau pressure at least below 24. So naturally, you will compromise up to the other ventilator will compromise up to 30. So naturally, you are already giving a benefit. Or beyond that, when you give that lung protection with that benefit, you are giving a lung is still protected. In the stress and strain on the lung because of the whatever the movements or whatever happening, the on ventilator, whatever is totally protected. Then, as you said, then the proning is going to give any additional benefit is very.
But Ajit, all those that you are talking, the patient is already on neuromuscular blocker, so much of it, all those side effects could have been abated. Because
even all the tidal volume, even possibly is lost there, the tidal volume, the plateau pressure, the PEEP, everything has been, it is already in ultra protective sort of mode, is already provided. That's what I convey. So that is very unlikely to produce a benefit, very unlikely. But as you said, probably some of the patient, as you said, in on ECMO, there is a refractory hypoxia on ECMO. Might be, these patients, obviously, there could be some experience or whatever observation could be that probably the oxygenation may be improving.
So I think,
I'll go by Pradeep's explanation of probably prone ventilation has provided a better hemodynamics to the things. The RV pressure overload, which we see in ARDS, is significantly mitigated by the prone ventilation. That may be a small explanation, but we cannot say for sure.
So Pradeep, and this is to allude to what PROCEMO also showed, the same thing. Cardiac arrests were more in supine as opposed to prone. And it was statistically significant.
And this is true here
it's very similar. Yeah, so it's very similar findings, Nirbal.
So it is the RV dysfunction that has been given the benefit
one of them.
Yeah.
One of them.
Shriman, Simon,
Especially as Ajit has said,
Yes, sir.
that-
yeah,
Yes, sir.
Simon,
Especially
can you show your face on the camera? I'm coming to
Yes,
you.
sir.
Do you think a different primary outcome could have been given more meaningful result in this in this study? A different outcome, a different primary outcome other than the one they used. I'm going to you and I've been coming back with the same question to Yudhvir. Yudhvir, do you think that a different primary outcome and a calculation of sample size based on that, maybe it could have been mortality also, who knows? But rather than weaning at 60 days from ECMO, as an outcome may not be a good lasting indicator of how successful prone ventilation can make ECMO. Yes, Simant.
Sir, this one 86 plus 84, 170%, definitely. They could have considered another primary outcome. But in this study, what we have seen, there is very low secondary outcomes like cardiac arrest and other things, bleeding, thrombocytopenia, those things are very less. So we could have considered
Adverse events.
adverse events are very low.
Adverse events. I am talking about choosing something else as a primary outcome. Because whenever we choose a primary outcome, this is the outcome on the basis of which we calculate the sample size. And the significance is always determined on the basis of the calculated sample size that is derived from the primary outcome.
No, sir. No, sir. It's almost it could have been the same. Most of the things have been covered.
Yudhvir, do you think that, yeah, you are muted.
You're muted, Yudhvir.
Sir, the primary the plan of the this RCT was that to compare the PRONECMO and supine position ECMO outcome. So we have to compare with the ECMO withdrawal or ECMO weaning. So I think we have to compare the ECMO weaning how many days the patient after weaning from the ECMO is free or living life. So somehow we have to calculate the 60 days or 90 days or 120 days. We have to calculate on the weaning outcome of the patient. But so ultimately the patient has to be weaned off from the ECMO.
Supradeep Ghosh, Dr. Ghosh, do you think that since these patients, almost 90% of them had COVID and it is the pulmonary ARDS, and there has been distinctly shown in earlier studies that extrapulmonary ARDS and ARDS respond differently, both to ECMO as well as to prone ventilation. So whenever we are looking purely to one pulmonary ARDS and subjecting them to the both forms of care, prone ventilation and ECMO, probably that may not reveal the true story.
But the biggest difference what I can gather is the extrapulmonary ARDS have a better compliance. Lung compliance is much better. And if you see the subgroup analysis of this patient, this thing, even whether the compliance is less than 20 or more than 20, the result remains same. So
Sir,
I think this will not, but you know, you
sir,
may be right.
Sir, in the earlier trial, what I have seen, two things were wrong with the earlier trial. I want to put my points here. It took 6 years. Here, only from March to December, this trial, PRONECMO trial. The number two, they have crossed, they were doing the BB-ECMO in 28% cases, they patients ECMO. And means the patients were the in-organ failures or more, then they were taken to the BA-ECMO. So that biasing was there in those trials. Here you can say very few cases they have gone to the BA-ECMO. So this is the good one. Secondary outcomes are good, and it has taken very less time. That 6 years is a very high time, means they were tired. So, and mostly those patients in earlier trial, they were septic shock, the bacterial pneumonias and other things. So here we have, okay, definitely. But
the earlier trial has different perspectives. We wanted to test whether it can be successful in all settings across all settings.
The inclusion criteria was very strict in the earlier trial. And earlier trial is different.
But the time taken was very long, 6 years.
Absolutely, because the inclusion criteria of earlier trial was very, very stringent.
So to reach that sample size, you will definitely need more time.
And compared to during COVID, we had the liberty of using many things.
Yeah, yes, sir.
Like the earlier.
So that was with this study, sir. because lot
Excellent.
of patient
So
recruitment.
this was during COVID time. So
Hmm.
we were desperate. Whole medical fraternity was desperate to do something for our patients.
So the kind of thing that Eolia noted was that and also we have seen that the same that many times the centers which were more experienced in prone position came out with better results. So the initial studies.
Yes, sir.
So can it something translate into like this in ECMO too? That the patient, as this study has found no benefit between supine and prone ECMO, but subsequently over years, as they gain more greater experience in prone ECMO, they will definitely show results. The same thing which we had seen in PROSEVA trial when we look back and see that the institutions did not get.
I feel it is strongly possible. I feel
So,
it
but
is very, very
but
strong.
I agree with Supradeep sir. Definitely, before putting the patient on ECMO, 1, 2 sessions, 3 sessions, more sessions of proning should have been done. Should be strict enough. Nothing like that. Like straight away you put the patient on ECMO, because we don't know whether the patient could have come out itself, or ECMO is advantageous in those conditions. So it should be more strict, like your earlier trial. I agree, fully agree with you, sir.
No. Once this is a randomized trial, so whether the patients have been given, it is equally distributed in the two groups. So whether they have written some patients will receive 5 sessions of prone positioning, 6 sessions before. So once randomized, the chances are 50-50. So I think that will a randomization negates away. But what is important is that whenever we do such a trial, the kind of resources, Dr. Pradeep, do you think that if we want to repeat this study or replicate this study in our setting in India or anywhere in South Asia, do we have sufficient logistic or financial support to conduct such a trial? A bit off track, but I think if you like to.
Yeah. So just to clarify one aspect, I think which we have been discussing over last 4 minutes, just to re-emphasize and alluding to what Supradeep and Seemant have said, the primary outcome cannot be any different. The reason I'm telling that is, even if you read the discussion very carefully, Yudhvir can allude to this. They mentioned by shortening the duration of ECMO, which is the weaning, the mortality can be significantly reduced. So they have attributed the mortality to all the complications with prolonged ECMO period, which is neurological, bleeding, new infections. And all of you who are doing ECMO, you know very well the deaths happen due to the secondary events, which is due to the length of the ECMO, like the duration of ventilation, which becomes the duration of ECMO, which again has to remain at the forefront to reduce the mortality. I think that appears to be the premise or the philosophy behind this study, and probably that will continue. So just correct me, Supradeep, if my thoughts are resonating the way it has to be.
Sir,
I fully agree.
Sir, in this case, both prone ventilation 28 days median days, and in the supine 32 median days. So you want to say it should be reduced?
No. I'm only talking about the study methodology where they looked at the primary endpoint, which we had discussed earlier, Simon, that primary endpoint looks like a good endpoint for our future studies. Coming to Anirban's question,
Yes.
if we embark on doing this study, say in India as a multi-centric from the ECMO centers, because India is doing a lot of ECMO. Now we are talking about another COVID wave that is coming, and albeit clearly understanding this may be a mild COVID. So it is possible, Anirban. The answer to your question is definitely possible, because here France is a very small country. Maybe it is as small as the Karnataka state, and they have taken 14 ICUs. India has so many ICUs, and so many people are doing ECMOs now, and so many centers are doing ECMO. It is very much feasible. We can do it with a much larger number than this. Here they've only looked at 170. 170 is nothing for India.
And what is the reason? I come to Ajit to that. I will go back to Dr. Supradeep also, but before that, I will go to Ajit. Why do you think that these results are really excellent? There has been no deviation in protocol. Almost all patients followed up, no loss to follow up. And the kind of meticulous way the study has been conducted is phenomenal, which normally is not seen, because many of the sometimes data go missing, sometimes patients go missing, and sometimes patients are terminated, that ECMO is stopped or something like that, which fortunately this study has shown that it has gone as perfect planning. The planning has worked totally. What do you think may be the reason, Ajit?
Yeah, maybe some kind of a bias, open label, then, like some kind of a bias might have been there. That's the only thing which I can say, but maybe when they are more experienced, researchers, that could be another way why you can explain that.
Dr. Ghosh, how do you think that perfect way of conducting this study, which is really difficult? Yeah.
First of all, I wish Pradeep is right, but I think our ECMO program in most of our centers are like Theodore Kolobos, 1970s. This thing, we are still handling with the ECMO, and COVID has given the right to everyone to do ECMO, whether they are ECMO center or not, whether they are trained or not. So I don't know, maybe in future. And but I must. That's the reason I would like to congratulate again to this thing, that the meticulousness in which they have done it in such a difficult time. It's a. I think their nurses are much trained than us. Our nurses attrition rates are. ECMO is a whole team effort. The nurses, the technicians, their attrition rate is extremely low compared to us. So they can do it, and the nurse to patient ratio are one. It is they are all trained nurses, trained technicians. Nurse to patient ratios are relatively, it's mostly 1:1. But here, even in ECMO cases, I don't know what is the ratio followed in many of our centers. So maybe because of this.
So I think that in most of these patients, because all of them had COVID pneumonia, and it's ARDS, it's VV ECMO, it is primarily femorojugular, and the duration has been more or less similar, and we had a very homogeneous group of patients. Do you think that in ECMO too, if we include the non-respiratory causes of ECMO, there can be a lot of heterogeneity, and this study may not be valid for such patients?
Then you would have to take more than 6 years time, because in non-respiratory causes, extrapulmonary ARDS, their prognosis are always much better.
Always.
They have a much better compliance. So to get a patient, pakad ke lana ECMO karane
is a challenging. We have exceeded. Yes, Yudhvir. Yeah, tell.
Sorry, in that it was because of the only majority of the patients were of the COVID-19.
Yeah.
That may be one of the reasons that homogeneity of the patient was maintained.
Homogeneity. Homogeneity is good, but even heterogeneity would have made some differences, but those differences would have been to be evaluated. We don't have any question on the chat box, but we have already exceeded at the time. So
yeah, Anirban, just to add to what Supradeep said, although I may have sounded over optimistic that we can do this in India, but let me be a devil's advocate. In India, I don't think we have machinery yet to do any randomized control trial. I think period, because I think tell me what randomized control trial in ICU we have produced until now. We have been pulling out guidelines after guidelines, and we are doing some sort of an observational multicentric. So the reason why I say that is because I was in Australia. I know how randomized control trials are done in public hospitals. There is a systematic machinery put in place in France, because you see all good randomized control trials come from France, because public funded. It is funded by the government, and you are doing it in a public hospital. So Yudhvir, who is in All India Institute, you have so many All India Institute now. These are the people who need to put machinery in place to do some robust trials. I think as a private sector here in India, which is predominantly doing the work in intensive care, I don't think we have any machinery, and we can keep beating our chest saying ISCCM, we do that and this. Nothing we have done with regards to any trials. Not even one trial we could do. We can do also. So that is the way forward, Nirban. So I think Yudhvir can be a leader, and the people from such institutes can take on the championship. And I think government has to be a party to such activity. Otherwise, we cannot do such quality randomized control trials.
We fully agree. So since there are no questions, yes, Yudhvir.
What I want to make that, I think majority of the patients they have done the study was the COVID-19. I think they have restricted this study to the COVID-19 only, because 6 and 9 patients they have taken from the non-COVID ARDS.
True. Very, you are correct. So since we don't have any question on the chat box, we would go to all of the speakers for 2 important messages that we can take from this study. And I will start with Shimant. Shimant, 2 important messages that you want to accrue from this study.
So my this one is keep proning. Do proning whenever you are thinking that driving pressure is high, when the ventilative pressure is high. Do proning, and definitely ECMO in proning is going to help, because what we have seen here, very few secondary adverse effects are here. Like in Eolia trial, we saw a lot of bleeding and other things. So those things are not here. And still, so whether we do ECMO in supine or proning, but proning has to be done. We should give a fair trial, because in India, we don't have that much resources. So we should do the proning at least for 16 hours for 4 or 5 sessions. Then we should consider ECMO. But patient selection should be good before 7 days. It's nothing like that. Lung fibrosis there, everything is there. Then we.
Okay, I get your point. I get your point. Yudhvir,
Yes,
two
sir, I think
important messages.
whenever we are going for the ECMO, before going for the ECMO, we should give the proning session to the patient. Whatever the 3 or 4 sitting, depend upon the clinical condition of the patient, then we can plan for the ECMO. And it totally depend upon the clinical condition of the patient, whether can we go for early ECMO or late ECMO. So that is or whether we start with the prone position, and so prone trial should be given, and then we decide accordingly.
That's an interesting question you have raised. I will go to Ajit, but before Ajit gives his two important messages, I would just like to that whatever Yudhvir has just now said, we know that many patients cannot be made prone in considering the indications and contraindications, but they can be given an ECMO. So do you think they need a second trial or a chance for a prone position during ECMO? Yes, Ajit.
So that's it. So before that, I would like to say that in my practice, we never ever prone anybody on ECMO based on whatever we had a very good opportunity for experience in ECMO during the COVID time, and we had a reasonably good result. That's what I would like to say. But as I said, there is we are never ever prone any patient during ECMO because of the anticipated common sense adverse effect like dislodgement, unnecessary proning, routine regular proning. I mean to say. It's like, the dislodgement of the tubes and all kind of things. Like that is one thing. So this trial also, whenever there's severe hypoxemia, we used to consider other options. Like, we used to think about, increase the area of membrane oxygenation, maybe putting another circuit and all. Very rarely we have considered that. And, in this, but I understand that maybe some occasional ECMO patient which I come across where there's a severe hypoxemia, I may consider proning, as when refractory hypoxemia. But otherwise, based on this result of this study, regular proning of an ECMO patient, I won't be practicing in my settings. That's what I want to get.
Final messages from Pradeep.
Yeah, so I can be a little skeptic here, Anirban. So it took 30 years to get a positive study in a normal ventilatory ECMO. And if you see the Gurin, who did the study, he had done a similar study with 800 patients way back around 15 years back, and he got a negative outcome. So I think it is not sacrosanct that it is only the prone that helps. It is the combination of multiple variables that influences the outcome. And I agree completely with Supradeep. We have to congratulate this French team because proning an ECMO is an arduous task. It's a very formidable and very labor intensive, and they have done for 170 patients. So that is, half of those, which is itself is a phenomenal. So I would wait for more data. I wouldn't now do some exercise and do all these theatrics of proning and anyone on ECMO because we are not there. And we have to still improve our ECMO outcomes, and because 50% is the mortality in this study. So in India, it may be a little more. So I need to work more on the basics, need to get all the other variables to save the patient rather than getting into theatrics of proning and ECMO at this point of time.
So what about the last answer to my last question? Do you think all the contraindications of prone position also apply during ECMO, or they become less rigid, that you can make patients prone? If the patient is on ECMO,
I think I would be more rigid rather than less rigid. My answer would be I would be more rigid with the criteria.
Dr. Ghosh, your last words from this study.
So there are 3 points, unfortunately.
Please go ahead.
Am I permitted? Okay. The first point is, as I completely agree with Pradeep, we have come a long way from the very early days that we have learned from a lot of randomized control trial that it is not only one particular intervention, it is a lot of intervention. And not only, let's not forget that even proning, ventilation, they don't make our patients survive. It is the overall ICU care which has improved that also make our patients survive. So this is one thing, and it is heartwarming to see that more and more patients are receiving, receiving evidence-based all these interventions. Like we have seen the proning 70% in Yolia, and now it is more than 95% in both groups. Now coming to this thing, what I learned from this study is, number one, I think one should take into consideration their resources before utilizing any intervention just randomly. So whether our system is ready to have you need huge labor intensive things in a patient who is on ECMO. Proning as such is labor intensive. ECMO is more labor intensive, and combining them together, so we need to consider our resources. And second thing, if you have resources, then probably we need more data just to say that proning will not have any help in patients who are already on ECMO. Probably we need more data. But collecting that data will be a huge, robust task itself. Probably
accumulating this data will be easier in the coming days with the application of AI, and I'm sure that we can use those most robust data to the best of our knowledge. So dear friends, there was a time when doing a proning during ECMO was considered as next to impossible, but today we have a study which has a large number of patients and in whom it has not been found to make any difference, but equally it is based upon a lot of observational studies, retrospective studies which show benefit. So certainly in the days to come, the cumulative data will give some direction on how and when to make the application of prone positioning during ECMO, at what stage, at what duration, to which conditions. And definitely those days are not far away, and those will be the brighter days where probably much better results can be applied, much better results can be obtained. And this 60% number, which seems to be too high, will also seem to be a minuscule. Thank you very much for being with us tonight. And we will come back on our second and fourth Fridays with our regular shows, Rapid Journal Review, with more interesting Journal Club discussions with new team. Till then, be with us. And as always, Shubhratri, Shavar Khayat, good night.
Thank you, Anirban. Thank you, Supradeep. Thank you,
Thank you,
Seeman. Thank you all.
Thank you, Yudhavir. It was well presented. Yudhavir, thank you so much.
Yudhavir won the better battle.
Yes.
Thank you, Yudhavir.
The slide was changed.
Thank you so much.
Thank you all. Have a great weekend. Thank you.
Sir.